Good morning, everyone. Today's lecture topic is pharmacokinetic session. So far, we have seen in pharmacokinetic how the drug is get absorbed and how it get distributed among the body compartment. Today, we are going to see other two mechanisms in pharmacokinetic, that is metabolism and excretion. And I am Dr. Mohammad Shuja from Department of Pharmacology. So far we have seen how a drug gets absorbed, how it gets distributed among the body compartment, and few pharmacokinetic parameters or concepts like bioavailability, plasma protein binding, and few other stuff. So why you need metabolism and elimination from your body? Because mainly you need to destroy or excrete the drug which you have been taken. So after the distribution, it acts on the site and the drug action is done. After the drug action, you have to mainly get rid of the drug. The metabolism and eliminations are mainly for get rid of the drug. Okay, mainly. So, what is drug elimination? Elimination is an irreversible loss of drug from the body. It has two components, metabolism and excretion. Few drugs get metabolized and then excreted. Very few rare drugs, you have to remember the name, they are without any metabolism, they directly excreted via the renal or GI tract. So what is drug metabolism? It is a chemical alteration of a drug in a living organ. The main purpose of metabolism is to make your drug, usually the most of the drugs are lipid soluble and unionized. So you are going to make the lipid soluble into water soluble, unionized into ionized, because water soluble and ionized form are very easy to excrete. So your purpose of the metabolism is to transform or biologically transform a drug into more excretable formula. That means you are going to change a lipid soluble drug into water soluble drug or unionized drug into ionized drug. I again repeat, the ionized form and water soluble form are mandatory or essential for the easy excretion of the drug from your body. Because usually ionized and water soluble compounds are not reabsorbed in the renal tubule and are excreted. If the parent drug is highly polar, it may not get metabolized and is excreted. So if it is highly polar, already it is a kind of water soluble. So it easily moves out of the body. So drug metabolism, it has it's a kind of set of enzymes which act on drug and do a biological transformation for the drug component, and that makes the drug excretion easier. That is majority of the drugs. There are two type of reaction: phase 1 reaction and phase 2 reaction. Both phases decrease lipid solubility. That means increases water solubility. So it facilitates the renal excretion. So how this metabolism of the drugs changes this biological activity? One, it reduces lipid solubility. Two, it altered its biological activity. What are the ways it altered biological activity? One, if there is an active drug, after the metabolism, that drug becomes inactive. If it's an active drug, after the metabolism, that active drug can convert into another active form of a drug or active metabolite. Then inactive drugs, they become activated. Like there are few prodrugs. By now you should know the definition of prodrug and example. So the prodrugs, they comes into the liver and get metabolized and become active. So these are the few examples when active drug become inactive, active become active again, because the codeine, the active metabolite is morphine, so codeine is metabolized and become morphine. Diazepam is metabolites and become the active form oxazepam. And there are few prodrugs, they are in an inactive form. Once it gets activated or metabolized, it becomes active metabolite. So, what are the sites of metabolism? Mainly, the most important site is liver. Most of the drugs get metabolized in the liver. But there are other few places as well, like kidney, gut, lungs, and skin. So I told you there are two phases or two pathways. One is phase 1, we call it non-synthetic reaction. There is no synthesis or no adding of new molecules. You metabolize, like oxidation, reduction, and hydrolysis. And phase 2 or synthetic reaction, it is conjugation with endogenous substrate like glucuronic acid, sulfuric acid, acetic acid, and few other things. You conjugate the drug and you make it more polar, more water soluble. So it will help in excretion. So what are the phase 1 reactions? These are catabolic reactions. They bring about changes by oxidation, reduction, and hydrolysis. So major enzymes participate for phase 1 reactions are cytochrome P450. So the pathways for phase 1 reaction. You should know what are the reaction happen in phase 1, what are the reaction happen in phase 2, because that is the common MCQ. So what is oxidation? You all aware, addition of oxygen or removal of hydrogen. That is oxidation. What is reduction? Removal of oxygen or addition of hydrogen. And what you should know is, you should know at least 2 or 3 examples for each type of reaction. So what are the like? We may ask the question, which of the following drugs undergoes oxidation in phase 1 reaction? So we may give a set of drugs. You should be able to pick the right one. Okay. So usually phenytoin, phenobarbital, and propranolol, they undergo oxidation and reduction, mainly methadone and chloramphenicol. And the third thing is hydrolysis. Via adding a molecule of water, you are going to break down the compound, mainly esters and amides, the local anesthetic. The phase 2 reactions are anabolic or synthetic reactions. They involve conjugation of new substances, and it results in the formation of very polar inactive. Why you need to make it more polar? Because when it's more polarized, it becomes more water soluble. When it is more water soluble, easy for excretion. And few phase 2 reactions are glucuronidation, acetylation, sulfation, amidation, and few things are there. They are mainly take place in the liver. If a drug molecule or a phase 1 product has a suitable handle, that means it has a site for receiving of a substance, it is susceptible for conjugation. So there are examples of each phase 2 reaction. We have to know the drugs. So what is the end results of metabolism? Mainly, you will, most of the time, after the metabolism, your drugs become inactivated or it become inactive. But as I already told you, if it is a pro-drug, after the metabolism, it becomes activated, but it is a small portion of drug. So remember it. So the mainly, if the phase 1 metabolite is polar, if it is enough for the excretion as a water soluble one, it is excreted by the kidney. No problem at all. However, many metabolites are lipophilic. That means they like lipids. So from the tubular membrane, there's a chance of getting reabsorption because lipid soluble ones are easily goes across the cell membrane. We have studied in last lecture. So if it is still lipophilic, you need to conjugate with the endogenous substance and make it water soluble. So once you conjugate, they become polar, inactive, and water soluble. So it is easy to excrete. So the drugs, most of the drugs, they follow phase 1 reaction, then again phase 2 reaction, and excreted. Few drugs, after the phase 1, if they are too much of polar, they directly excreted. They don't go to phase 2. Some other drugs, they don't have phase 1 reaction, they straight away goes to phase 2 reaction and get excreted. Some other drugs, they first undergo phase 2 reaction, then goes to phase 1 reaction, then excreted. And few drugs they excreted in the unchanged form. You should know examples for each of the entity. Okay. So if MCQ points come, in the drug metabolism, the drugs always undergo phase 1 metabolism That is false. Because these set of drugs, they never undergo phase 1. So you should be able to tackle the MCQs with the knowledge gained from these slides. It is again the easiest way of understanding. If the drug is highly lipophilic, that is, if it is lipid soluble, it gets accumulated in the cell and it undergoes phase 1 metabolism, become polar, then undergoes phase 2 and become water soluble, then excreted. So there are enzymes helps in metabolism of the drug. There are two kind of enzymes, microsomal and non-microsomal enzyme. The mainly we categorize, one of the easiest ways to remember the difference between microsomal and non-microsomal is to know the sites where they present. The microsomal enzymes are present in the endoplasmic reticulum, and non-microsomal enzymes they are not present in the endoplasmic reticulum ER, but they can present in the cytoplasm, so cytosol, nucleus, other parts of the cell. So microsomal enzyme, they mainly catalyzes most of the phase 1 reaction, and in the phase 2 glucuronide conjugation or glucuronidation. It mainly present in the ER of the cell. Examples are cytochrome P450, that is the phase 1 reaction, and glucuronyl transferase for the glucuronidation. So non-microsomal enzymes are they found in the cytoplasm and other part. They catalyzes all the phase 2 reaction like other conjugations except the glucuronide conjugation. Usually they show genetic metabolism and are not inducible. Now we'll just have a look through P450 system. They all microsomal enzyme, that's the common MCQ point. And these are all heme protein. You know what is heme, right? The heme is found in the hemoglobin, right? The heme protein. So if they are referring the enzyme using a CYP classification. So they say for one enzyme it is CYP1A2. CYP means the group of the enzyme, microsomal enzyme. One is denoted to, that means after the numeric which comes after CYP, it is denoted to the family of the enzyme. Then you will get the alphabetic letter. That is denoted to the subfamily of the enzyme. Then again you get the numeric number. That is denoted to the exact isoenzyme type. So they are usually found in ER, mainly liver, but also found in GI, kidney and lung. CYP3A4 and CYP2D6 are responsible for most of the drug metabolism. If I am right, CYP3A4 is almost responsible for 50% of the drug metabolism happen in your body, and CYP2D6 is around 20 to 25%. So most of the almost 70% of the body's drug metabolism is controlled by these two enzymes. So there is another thing called enzyme induction. There are few drugs, they are going and in the liver they increase the synthesis and activation of the microsomal enzyme. When there is too much of microsomal enzyme, what will happen? It will increase the metabolism of the certain drug which they assign for. When metabolism is increased, what happened? The concentration in your body is reduced for that particular drug. When the concentration is reduced, the effect which we are expecting from taking the drug is no more. So if you are already on a drug and if you are adding an enzyme induction drug or enzyme inducer, then the effect of the previous drug may be altered or reduced. So you should be aware of that because you are prescribing multiple drugs for the patient. Then you should know what are the enzyme inducers, what are the enzyme inhibitors. So if you are going to giving an enzyme inducing agent, you may need to increase the other drug. If you are going to give enzyme inhibitor, then the metabolism is reduced for that drug. So drug concentration is increasing. So in that situation, you may need to cut down the drug dose. So these are the basic idea of enzyme induction and enzyme inhibition. And you should know few examples of that. Like rifampicin, phenytoin, barbiturate, carbamazepine are mainly enzyme inducers. So when you give these drugs with other drugs, the other drugs metabolism is increased. So the effect is reduced. So there are few clinical importance of enzyme induction. They commonly ask in the exam. So when you are taking oral contraceptive pills with rifampicin, there is a failure of OCP because rifampicin is the enzyme inducer. So it increases the microsomal enzyme activity which are responsible for breakdown of OCP to ethinyl estradiol and progesterone. So when they break down the OCP, the contraception effect is not there. So they may get conceived. So that is the OCP failure. Then there's a drug tolerance and drug toxicity. Then other thing is osteomalacia produced by prolonged phenytoin therapy. The phenytoin again is the enzyme inducer. What phenytoin does it goes and activates the enzyme responsible for the vitamin D calcitriol metabolism. Vitamin D is needed for the calcium reabsorption in the gut. So when there is the increased metabolism of calcitriol, the calcitriol concentration is reduced. So calcium reabsorption from the gut is reduced. When there is less calcium reabsorption, less calcium in the body, less calcium for bone mineralization, it leads to osteomalacia. And precipitation of porphyria promote rapid elimination of drugs also possible. The precipitation of porphyria is something to play with heme component. And another very important than earlier used phenomena, but nowadays they are not practicing. You are going to give phenobarbital in neonatal jaundice. Now all of you have done pediatric appointments. Neonatal jaundice is there is bilirubin in your body, Baba's body. It is unable to conjugate it and become excreted. So phenobarbital is the enzyme inducer. It goes and induces the microsomal enzyme, which is responsible for bilirubin conjugation with the conjugate. So when the enzyme activity increases, the bilirubin, which is the problematic one, it becomes conjugate and they become polarized or water soluble and they excreted. That is a good thing for your body because this practice was earlier used long time before. Nowadays they are not using commonly. So these are the few clinical importance in related to enzyme induction they may ask. So I have explained you three. You have to find and know the explanation for rest of the things. So enzyme inhibition I have explained. You have to remember the example. Erythromycin, azole, ritonavir, like that. So this is just a basic idea to say the lipophilic compound, they undergo metabolism, increase excretability because it becomes water soluble or hydrophilic. Now we will going to look at the drug elimination. So the removal of drug and its metabolite from the body is eliminated. So there are routes of elimination, like there are sites for metabolism. The main site for metabolism is liver. Main route of excretion is kidney. But from the lungs, via feces, via bile, in the skin, and through saliva or milk also, excretion of the drug can happen. So what is clearance? Know the definition. It is the volume of blood that is cleared of the drug per unit time. That means if you take 1 hour, you are going to measure the amount of blood that is clear from drug. So the total body clearance is not only the hepatic clearance, but also the renal clearance and pulmonary and few other ways it can get cleared. The total body clearance is altogether the sum of the hepatic, renal, pulmonary, and other means of clearance. So mainly renal clearance is we are going to emphasize. Then you know the clearance, like creatinine clearance during your physiology. So just remember that. So there are three ways in the kidney the drug can get excreted. All three ways are fundamentals of renal function. One is glomerular filtration. Other one is active tubular secretion. Third one is passive reabsorption. So after the filtration and active tubular secretion, few are going to get reabsorbed. So the sum of these, that means rate of infiltration plus rate of secretion minus rate of reabsorption, is the amount which is going to excrete. So if you remember your physiology, this is your blood vessel, this is your peritubular capillaries, and from the glomeruli, the Bowman capsule, the filtration is happens. And from the tubules into the, from peritubular capillaries into the tubule, active secretion happens. From the tubule into the capillaries, reabsorption happens. Then the rest is excreted. And there are few other things you have to do, because we have filtered something here. These are cell membrane. This is the tubule. This is the blood vessel or peritubular capillaries. This is the cell membrane. Cell membrane is easily permeable for lipid soluble drug. And if we are having a lipid soluble drug here, what will happen? It may get reabsorbed easily into the peritubular capillary. So it is again going into your system. You got my point? Because when you filtrate, the drugs comes here. If the drugs are too much of lipid soluble, it will again passes through or go across the membrane and enter the peritubular capillary. That means your systemic circulation. So how we are going to reduce this reabsorption and increase the excretion? So remember, I taught you how weak acid and how weak base get across the cell membrane. Imagine if you are having a weak acid. So weak acid is, if we take hydrogen and a drug component, we say it HA. HA is the weak acid component. So in here, there's an equilibrium for that drug. It will release H plus ion and become A minus. That is your drug component. So this H plus and A minus both are polarized. The conjugate of that HA, acid plus drug, is not polarized. So the not polarized HA component can go across the cell membrane and get reabsorbed. So in which form you want to keep the drug here? It's compound with or conjugated with acid or in H plus and A minus polarized. You want to keep the drug in polarized, because if it is polarized, that is water soluble. It cannot get reabsorbed through the cell membrane easily. So it will excrete. So to make the weak acid become polarized, what you are going to do? You are going to add bicarbonate. When you add bicarbonate or alkaline medium, the alkaline is bound with H plus. So the reaction is shifted to right side. From HA, it will release H plus and the drug A minus component. Okay. So more polarized portion of drug is there. More polar part. So they excrete easily. For the weak acids to excrete without reabsorption, you are going to make this tubular fluid alkaline. For the weak base, to increase the excretion without reabsorption, other way, you are going to make that tubular fluid acidic. You got my point? I will explain it later, but you have to work on that, okay? So there are glomerular filtration of drug. They mainly depend on the molecular size and glomerular filtration. Those the hydrostatic pressure. The more hydrostatic pressure, more drug filtered and binding to plasma protein. If more drugs bind to more plasma protein, what will happen? They bound. Their size is increased, so unable to filter. So less drugs come for the filtrate. So the less drug will be excreted. The active tubular secretion, it is carrier mediated one, and the very important thing is the probenecid increases the duration of action of penicillin by retarding its tubular secretion. Usually, penicillin is secreted by into the tubule for excretion. So they have a kind of carrier. The probenecid goes and block that carrier. So penicillin cannot actively secrete into the tubule and get excreted. So it will stay inside the blood. So the more time it stay inside the blood, the prolongation of duration of the action. So that becomes effective in bacterial killing. That is the explanation for this. And again, this is a very common question they will ask. Okay, that is in relation to active tubular secretion. And passive tubular reabsorption, this is what I have been talking so far, mainly influenced by the degree of ionization. Anyhow, strong acid and basic drugs are ionized and they excreted. Weakly acidic drugs in acid urine remain mainly unionized and reabsorbs into the circulation. To make it more ionized or polar, we need to add alkaline into the tubular lumen. See, if the pH of the urine is made alkaline by sodium bicarbonate, the drug gets ionized and is excreted easily. Same thing happened to basic drugs. Weakly basic drugs in alkaline medium remain unionized, so they get reabsorbed. If you are going to add acid to that tubular lumen, the basic drugs become ionized, that means polar, that means water soluble, and they excreted easily. If you don't, if you understand now, that is fine. If it is not clear, what you have to do is you go back to this slide and listen again to my explanation and come back again, you will understand. So drugs which are excreted largely unchanged in the urine, you have to remember these examples like furosemide, genta, and there are other places where the excretion happens. Lung, feces, bile, skin, and saliva, and know the examples. And now we came for the very important concept. What is half-life or T-half? T-half or half-life. From something, we are going to reduce it to half. That is half-life. So the definition, the time required for plasma concentration of the drug to reduce by half of its original value from time 0 to time x. If it is 100 on time 0, by time x it should be 50, half. If the initial thing is 50 at time 0, but time x it should be 25, half. Half reduction from its original volume. The time taken for the half reduction from its original volume is T half. That's it. Why it is important? Because T half will influence in deciding the duration of drug action. Because if you know the duration of action, only you can give drug in certain time interval. So the T half will decide your drug administration frequency, and it needed to calculate the time required to reach the steady state of drug. Usually 4 to 5 half time will needed for that. So you are giving an IV injection. So within few milliseconds, you will get 100% because for the IV, how much is bioavailability? 100%. So amount you give all the amount will reach the plasma for the IV because bioavailability is 100%. What is bioavailability? Okay, if you don't remember, pause this and go and check that and come back. It is in the lecture 1. So if you give the IV, total concentration will be there. Imagine it is 100% or 100 milligram, whatever. So the time taken that to reduce by half. So what is the half of the 150? So the time taken for this 100 to come down to 50 in the plasma is half-life. That's it. So what is the next half-life? From 50 to half of that, 25. So where the 25 come? That is next half. So imagine the half time is, for majority of the drug, the half time is 5 minutes, and after the next 5 minutes, that is at the 10, after 10 minutes, it will be 25. Again, after 10 minutes, it will be 12.5. That is how it's come. Half of the previous concentration is reduced for every T half time. So this is what I told you. It become half, then 0.5 become half, 0.25, 0.25 become half, 0.125. This is become half, 0.0625, like that. So the time taken for the 50% of reduction from its original amount, that time is constant. So 50% of the drug is metabolized or excreted from your plasma. The time is equal, but not the amount metabolized in each time interval is equal. Okay. So this is a hypothetical distribution of half-life. At the first T half, it becomes 50%. Then again, 50% of that 50, it is 25. Third T half, 50% of 25, that is 12.5. That is how it goes. So if you are going to draw a linear concentration time graph, it will give you an exponential graph. It is equal exponential. The half-lives are same, but the amount metabolized or reduced or get rid of from the plasma is not same. But the fraction is same. 50% of the starting concentration. Okay, know the difference. The T half is same, fraction of the reduction is same, that is 50, but the amount is, the reduced amount for each T half is varies. If you are going to take that in the logarithmic graph to make it easier, it will give you a linear graph like this. So each half time 150, 25, 12.5. Even though this amount is different, but the gap looks same because it is semi-logarithmic. You have to know this graph and you should be able to draw this. Because if we ask, because there are other few things like kinetics, so we may ask you to draw this in your exam. So what is steady state? With a constant rate of infusion at one point, the drug's metabolism, that means the administration and elimination become equal. So you will gain a steady state of concentration in the plasma, that is steady state, that will usually you will get steady state concentration after 4 to 5 T-half of that particular drug. So this is how steady state is achieved. Initially, you give a drug, so the concentration is increases. Then metabolism happens, so the concentration is reduces. Again, after the T-half, that means only after every T-half you are giving a dose. So by the end of first T-half, 50% is reduced. Then you are going to give again next dose. So the concentration is increased. And from this 50% is reduced by next T-half. Then at the end of the second T-half, you are giving next dose. So the concentration is increased, because if you give 100%, only 50 is reduced by the end of T-half. End of the T-half, you are again giving 100%. So the concentration in the plasma is gradually increases. Okay. After 4 to 5 T-half or 4 to 5 doses, you give, if you are giving that doses exactly in the T-half, you will get a kind of minimal state. That means steady state concentration in this range. Okay. At this time, the amount you administered and the amount it gets metabolized is same. Okay. This is how you get the steady state concentration. Hope you understood. So this is a kind of explanation. So this is, if you are giving infusion, you are giving a constant infusion, it will be coming like this. But if you are giving intermittent boluses, it will increase. And after 5 T-half, it will come to the steady state. But if you are giving a loading dose, you are giving too much of high amount of drug, and again you give maintenance boluses, it will remain. So if you are giving a bolus, quickly you will achieve the steady state concentration. Okay, that is the advantage of giving boluses. Then intermittent doses, because if you are giving bolus and then maintain with intermittent doses, the moment you give bolus, you will achieve the steady state concentration quickly. If you give boluses, intermittent one, not the loading, without the loading, it will take 4 to 5 T-half to achieve steady state. It will take time. If you are in a hurry, if the patient is on shock, anaphylaxis shock, or any form of sepsis, you can't wait. You don't have time. So you'll straight away give a loading dose and the steady state achieved quickly. Then you maintain that with boluses. Okay? That's why we have to give loading dose. So what is clearance? Again, the fraction of the apparent volume of distribution in which, from which the drug is removed in unit time. That is clear. This is a fraction of the apparent volume of distribution from which the drug is removed in unit time. You know that. So this is the equation for clearance. Clearance equal rate of elimination divided by plasma concentration of drug. Then few mathematics. This is the equation. Know that T half equal 0.693. That is a constant. You can imagine is a 0.7 also. Into volume of distribution divided by clearance. So simple mathematics. If a clearance of a drug is reduced, what will happen? The drug will retain in the system. So its activity or duration of action is prolonged. So if a clearance of the drug is reduced, T half is increased. If the volume of distribution is increased, that means the amount of drug is goes all the part of the tissues in the body. The time taken for reduction from the plasma is also increased. That's why the drug with the increased volume of distribution most of the time will have large T half. Like that, you can tackle few MCQs via knowing this equation. There are few equations in pharmacokinetics. If you know that and using your mathematical knowledge, you can tackle most of the true false questions. Know this equation. And now I am going to teach you very important but easy concept, first order kinetics and zero order kinetics. The first and zero order kinetics are the way the drugs get eliminated from your body. The first order kinetics are a constant fraction of a drug is eliminated per unit time. Constant fraction, what is that? It is similar to the T half what we have seen. Each unit time, constant fraction. Earlier, if it is 100, then if it is 50 percentage of fraction, it will become 50. Then again 50 percentage of that 50 is 25. So each constant time, constant fraction of the drug is eliminated. But the amount can vary. The rate of elimination of drug is proportional to the drug concentration. The more you give the drug, the more it gets eliminated. Plasma concentration of the drug decreases exponentially with the time. Half-life of a drug that follow first-order kinetics always remain constant. But luckily, most of the drugs follow first-order kinetics. See, this is the graph I used to explain T half. So this is 100 after 1 T half or 1 constant. These time intervals are constant, and after 1 time interval, the 100% become 50. So the 50 percentage of reduction. After second, the 50 become 25. That means again 50 percentage of the reduction. After 30 half, the 25 become 12.5. Again 50 percentage of the reduction. So the fraction of reduction here is same for the each equal time interval. But the amount is not same. So the first order kinetics follow the principle a constant fraction of drug is eliminated per unit time. All these things are true false MCQ points. Remember it. Then zero order kinetics. A constant amount of drug is eliminated from the body per unit time, not the fraction. So the rate of elimination is independent of plasma drug concentration. Because however you increase the concentration, certain amount will be metabolized or eliminated. But from the first order kinetic, the more you increase the concentration, the more it eliminated. Rate of elimination is constant regardless of concentration. So the amount is eliminated per unit time is constant. The amount is constant. So the plasma concentration decreases linearly with the time. Half-life of drugs that follow zero-order kinetics is never constant. Remember this: phenytoin, salicylate, theophylline, ethanol, alcohol are follow zero-order kinetics. So here if you see this the same rate per unit time, same amount is reduced. Okay. What is T half? T half is from this amount to half. So if it is 100, somewhere here. So the time is this. But from this to half is here. So time is reduced. That's why for zero order kinetics, the T half is varies. Okay. The constant amount of drug is clear. Constant amount, not the constant fraction. Okay. You should know the difference between zero and first order kinetic. Here, first half time 5 units per hour, then second hour 2.5. So 50% of this. And the third hour 1.25. Again 50%. The fraction, the equal fraction, not the equal amount eliminated. Zero order kinetic, each hour 2.5 is eliminated. So constant amount. So if constant amount is eliminated, the graph is linear. Constant fraction is eliminated, the graph is exponential. You should know how to draw these two. It should be bread and butter for you all. Then MCQs and essays are very easy. So these are few examples you should know. Okay. And another wonderful thing you have to remember, I told you first order kinetics, because for the elimination you need metabolism, for the metabolism you need enzyme. The first order kinetics, the fraction is constant. So I told you, the more you increase the concentration of drug, the elimination also increases because you have enough enzyme. But at one point in your body, all the enzymes are saturated, even for the first order kinetic. Until the enzymes are getting saturated, the first order kinetic rules follow. The more you increase the concentration of drug, the more get eliminated. But once, for the elimination, you need enzyme. But once all the enzymes are saturated, even though you increase the concentration of drug, the elimination will not increase further. From that moment, the elimination rate is plateau. Increase up to the enzyme saturation, then plateau. So first order kinetic drugs at high plasma concentration, once the enzyme gets saturated, their elimination kinetics change into zero order. Remember that. Okay. So what is therapeutic index? It is a quantitative measurement used in pharmacology to assess safety and efficacy of a drug. Ultimately, whatever the pharmacokinetics parameters you study, the purpose of giving drug is to keep the patient safety with the effective dose, not to give them toxic. Okay. The therapeutic index is the ratio between lethal dose LD50 divided by effective dose. LD50 is the dose that is lethal, that is harmful in the 50% of population. Effective dose is the dose that is effective in 50% of population. So imagine you are having a drug. So at 5 milligram per deciliter concentration, that is effective in 50% of population. But to make lethal in 50% of population, you have to increase up to 50 milligram per deciliter. So therapeutic index is 50 divided by 5, that is 10. So the gap is from the safe dose, that is 5, lethal dose, that is 50. The gap is too much. If we have that increased gap, that is safe, right? Because at 5 milligram per deciliter concentration, 50% of the population will be okay. They will cure. But to make them harm, you have to increase up to 50 milligram per deciliter. That is too much. There's a huge gap. You have to give more drugs. Usually we don't give. So the therapeutic index, lethal dose divided by effective dose in 50% population is, for that particular example, 50 divided by 5, 10. That is therapeutic index. So the increase of therapeutic index means what? The drug is safety. The reduce in the therapeutic index, imagine effective dose is 5, lethal dose is 6. So accidentally or patient compliance is poor, they can take more drugs and they easily goes into the toxic effect. For that drug is 6 by 5, only 1.2. So therapeutic index is reduced. So the drugs with low therapeutic index are, we should be extra careful, and the safety is compared to drugs with high therapeutic index low. So this is what I say, higher therapeutic index indicates the drug is relatively safe. Lower therapeutic index TI indicates drug has a narrow margin of safety. So therapeutic drug monitoring. So it where or when you need to monitor the drug concentration in the plasma, like the drugs with narrow therapeutic index and drugs showing wide individual variation and blah blah. There are few indication you have to go through. And there are instances where you don't need therapeutic monitoring of a drug. So when there is a drug producing tolerance, even though you give more concentration of the drug, the effect will be reduced with time. So few indications just go through. Then very important things, what are the factors influencing the drug dosage? The time taken to act depends mainly on the route of drug. If you want to act quickly, you have to give IV. If you give oral, it will take time to come after absorption and distribution. Usually steady state achieved within 4 to 5 half time. But if you need the steady state to achieve quickly, you have to give loading dose. I have explained. Drugs with a short half-life need frequent administration or infusion to reach minimum therapeutic steady state. Because if it's a short T-half, the concentration in the blood comes down quickly. So you have to give more frequently. Drugs with a long half-life take longer time to reach the steady state. So you have to wait till 5 T-half. So you can't wait, you have to give the loading dose. What is loading dose? Loading dose is a large dose or series of doses of drug given to attain steady state concentration rapidly. I told you in the life-threatening condition where you need to get the steady state concentration quickly, like in the epilepsy patient. If not responding, you will give a bolus of anti-epileptic drug and then it will contain like that. The ventricular arrhythmia, you give bolus doses of lignocaine and maintain with the infusion. So this is the equation. The loading dose equal volume of distribution. This is the target plasma you needed and the bioavailability divided by bioavailability. So if a drug volume of distribution is too much, what will happen? If any drug is having a too much of volume of distribution, their plasma concentration is low because most of the drug distributed to the other compartment. So to get the quick target concentration, you have to give increased amount of drug. So if a drug is having increased volume of distribution, your loading dose will be high. The drug is bioavailability is low, again loading dose will be high. Like that, from the equation, you should be able to work out. What is maintenance dose? Is the dose required to maintain the steady state concentration after the loading dose is given or after 5 or 4 or 5 THAF is achieved. Once steady state is achieved, the amount we administered and the amount it eliminated are equal. So you have to give maintenance dose. This again the equation you have to go through and you have to try to work it out. This is the equation I have given. This is what is denoted by the thing. So imagine this is clearance. If a drug's clearance is very high, it's cleared from the system very quickly. You have to give too much of maintenance dose. You have to increase the maintenance dose. So how you increase the maintenance dose? Either you can increase the dosing interval. Okay. So these are the ways you have to think. You have to give maintenance dose. Either you can, if the clearance is too much, either you can increase the maintenance dose or you can increase the frequency of administration or dosing interval. This is how you have to work out using this equation. These are the few equations I will give you. If you know this and if you are able to work out, so imagine if this equation, loading dose is volume of distribution to target concentration by bioavailability. So if a drug is having increased amount of volume of distribution, you have to give more loading dose. Like that, you have to work it out using this equation. So there is a fixed dose combination. Rather than single, you give fixed to increase the efficacy or bioavailability of the drug. So advantage, disadvantage, just go through. The how to increase the prolongation of duration of action. There are few methods. For oral administered drug, you are giving enteric coated form or there are sustained release, SR, slow release like this. The parenteral administration, you have to add something which reduces the vascularity of the particular surface or reduce the solubility. So the drug will remain the plasma and it will give more effect. With that, we come to the conclusion of pharmacokinetics lectures 1 and 2. If you have any doubt, you can always email me or contact me via WhatsApp. And as I always say, may peace be upon you all. And thank you very much for being with me. Have a nice day. We will meet you at Pharmacodynamics series. Have a nice day, students.